Thanks, Bhavna, for a very kind introduction and also for including me in this instruction course. A very good morning to everyone. I will try to be quick so that we can be on time. So I'm going to talk to you about a very important component of chemotherapy for retinoblastoma, that's intravitreal chemotherapy. We know that there are various treatment chemotherapy options that are available, and intravitreal is one among them. Now, what is intravitreal chemotherapy? It is a targeted form of chemotherapy where we inject the chemotherapy agent directly into the vitreous humor. The aim is to treat the intraocular retinoblastoma and to minimize the systemic side effects. Now, why do we give intravitreal chemotherapy? Because the advantage of this is that there is direct drug delivery to the site of the tumor, and it has been proven that it is effective in eyes with vitreous seeding, where the other forms of chemotherapy may not reach adequately. Now, why is it that it was not popular before, but it is popular now? If you look into the old publications, it was feared that if we put a needle into an eye with retinoblastoma, it results in tumor seeding along the needle tract. And there is a risk of extraocular extension of the tumor and systemic metastasis. And that's why it was not being used adequately till the year 2012. So what changed in 2012? I think this is the publication which changed our complete understanding about intravitreal chemotherapy. This study was published by Munier's group. They used the intravitreal chemotherapy at a dose of the melphalan at a dose of 20 to 30 microgram dose, and they studied the effect in 23 patients, and they showed the most important message that came out through this paper is that there was no extraocular spread of the tumor in any of the eye, and they could achieve a globe salvage in 87% of the cases. So then started the era of intravitreal chemotherapy. That is the new era in the management of retinoblastoma post-2012. Now, what difference has it made? It definitely has made a lot of difference. It has increased the rate of globe salvage and reduced the need for radiotherapy, because previously if it was diffuse vitreous seeds, which could not be managed with other forms of chemotherapy, we would just send them for radiotherapy, which is no longer done because we have intravitreal chemotherapy. Now, if we look at the three eras of globe salvage, that is when we did not have IAC, when we have IAC, and when we have intravitreal chemotherapy, you can see the gross difference between the three eras. In the era one, that is when only intravenous chemotherapy was available, the globe salvage rates was less than 50%. In the IAC era, the globe salvage increased to 56%, but with the addition of intravitreal chemotherapy, currently the globe salvage for intraocular retinoblastoma is 85%, including 87% of group D eyes and 73% of group E eyes. Now, the drugs that are commonly used are melphalan and topotecan. But do we follow the same rule for every patient? Do we inject the same way? It's not so, because it's not that not all seeds are created equal. So in general, SEMA has already shown what are the three different types of vitreous seeds that we have. So for type 1, we need about 1 to 3 injections. For spears, we need about 2 to 4 injections, and cloud 2, we need about 6 to 8 injections, which are usually given once in 3 weeks. Now, the technique is very, very important. So it is given through the pars plana route, and it is very important to understand that we are injecting in children. So it's not that the pars plana is present at 4 millimeter from the limbus in every patient. It depends on the age. So in general, you take 1 millimeter for every year. So if it's a 1-year-old child, you inject 1 millimeter from the limbus, 2-year-old child, 2 millimeter from the limbus, 4-year-old child, 4 millimeters from the limbus, and beyond 4 years, you stay at 4 millimeters. And then after we inject, the most important step is to do the cryotherapy at the site of injection even before you withdraw the needle. So you basically withdraw the needle through the freeze and complete the triple freeze thaw cryotherapy at the site of injection. And you shake the eye well. This is because in a child, the vitreous is like a gel, so the drug will not disperse. So you just want to disperse the drug. You shake the eye, like wiggle the eye a little bit, and then give a thorough wash with saline, just so that you wash out any of the drug or any vitreous that has come out of the eye through the site. Now, of course, intravitreal chemotherapy has many good things. The good things here, so this is a child who received intravenous chemotherapy, and you can see that the main tumors regressed. But of course, there are vitreous seeds. The arrows point to the vitreous seeds. So for this child, what do? So you just give intravitreal chemotherapy, and you can see that the seeds completely go away. Of course, it has the bad things as well. Now, in this eye, there are good things and bad things that we see. Now, this is an eye with vitreous seeds, and you can see that with serial injections, the tumor has completely gone away, and that's the good thing, that we were able to salvage the globe. But you look carefully what has happened to the optic disc, what has happened to the vessels, what has happened to the health of the retina. So obviously, it's all damaged. So that's the bad thing as well that can happen with intravitreal chemotherapy. It can also cause the anterior segment complications such as this, where there is iris atrophy, the posterior synechiae that can occur with this drug. So these are various adverse effects that the intravitreal chemotherapy can cause. It can cause retinal toxicity and anterior segment toxicity as well. Now, we recently performed a comparative study of what are the effect of using melphalan versus topotecan. This is just published for those interested to read it. And what we concluded is that both the melphalan and topotecan are equally efficacious, but topotecan has better safety profile, especially in pigmented eyes. Now, there are expanding horizons of intravitreal chemotherapy. So this, if you remember the first slide that I showed, so I told you that it is effective for eyes with vitreous seeding. So what are the expanding horizons? Now, there have been recent publications which have shown that intravitreal chemotherapy, it acts beyond the intravitreal seeds. It is effective against the subretinal seeds. It is effective against the retinal tumor as well. So the expanding horizon is that the intravitreal chemotherapy can be used in selective cases for subretinal seeding and for intraretinal tumor as well. Now, here are some examples that we have treated. So you can see that this child developed recurrent subretinal seeds. We gave intravitreal chemotherapy, and you can see that without any other form of treatment, just intravitreal chemotherapy, the subretinal seeds, the retinal tumor, the epiretinal seeds completely went away. Now, the other new development is that this is the slide that I had shown before as well, where these are the two drugs and these are the doses that we use. There are reports now that high-dose intravitreal chemotherapy, especially topotecan, is also very useful. So the high-dose topotecan is almost 3 times the dose of the standard dose, 90 to 100 microgram in 0.1 to 0.2 cc, and it is very effective. And here are some of the cases that we have treated where we gave high-dose intravitreal topotecan when all other forms of treatment were not helping the patient. And you can see the response that the retinal tumor, the vitreous seeds, subretinal seeds, everything went away with high-dose topotecan. So to conclude, intravitreal chemotherapy in today's era, it is safe to be given in retinoblastoma eyes, but of course it has to be given by a trained ocular oncologist. It improves the chances of globe salvage. There is less need for radiotherapy. It is effective not just against vitreous seeds, but also subretinal seeds and intraretinal tumor. And high-dose topotecan is a new emerging option for the intraocular retinoblastoma. Thank you very much.
Thank you, Swathi. That was a very elegant